I took this challenge. This is a challenge, and my talk would be a talk of analogies. So I will try to convince you that there are analogies between the hypertrophy of hypertrophic cardiomyopathy and the hypertrophy we see in patients with hypertension. Let me start with the latter, just to move away from cardiomyopathies, at least primary cardiomyopathies, for a while. Now, I took this from a recent review by Dr. Dratzner from the US, and this is the view of how patients with hypertension may proceed to congestive heart failure. And here you will start to see some of the analogies. So the view is that you can either go through the way of progressive concentric hypertrophy and progressive diastolic dysfunction towards a restricted syndrome and develop heart failure, or on the other hand, you can develop a more dilated phenotype with systolic dysfunction, generally going through development of myocardial infarction. And we know that the incidence of coronary artery disease in patients with hypertension is much higher than in patients without hypertension. But on the other hand, there is another arrow that says no MI. So we know that at least half of these patients who develop systolic dysfunction and dilatation go to heart failure without any evidence of previous myocardial infarction. And if we look at this study, this is a meta-analysis. It was published about 5 years ago. And the incidence of heart failure in almost 8,500 patients was 12.9%. Now, we don't know from these data how many of these patients had CAD. But if we assume, right or wrong, that half of them did not have CAD, we have an incidence of about 6.5% of patients with hypertension that will develop congestive heart failure without any history of previous myocardial infarction. Okay. Second case scenario, we heard a lot about this. 5–10%, according to some will say it's less, some will say it's more. Patient with hypertrophic cardiomyopathy can either develop what is called ES, ipocinetico restrittiva, which I'm sure you can understand is the restrictive pathway, like the hypertensive, or they can develop end stage through an ipocinetico dilatativa, which is dilated hypokinetic. And this is the first analogy. So it seems that at least the progression towards heart failure in these two patient groups is similar. And if we take, this is considered to be the milestone of the end-stage progression paper. Here the incidence is about 3.5%. And importantly, this is a cause of death and morbidity in young patients. So almost half of the patients were less than 40 years old. And 66% of those with ES progressed to death. So it's a serious problem. Now, my point is, do these two conditions, i.e. heart failure in secondary LVH and end-stage hypertrophic cardiomyopathy, have something in common? What do you think my view is? Yes. And what do they have in common? Well, over the last 10 years, we have developed this concept of microvascular disease. I'm sure some of you have already heard this, and I apologize, but I think it's always worth to repeat concept. And what is the problem? That we normally focus on the large epicardial coronary arteries because in the past 50 years, almost every patient has got an angiogram, and this is what you see at the angiogram. And this is a fantastic technique, has changed cardiology, has changed the prognosis of patients with acute coronary syndrome, but has a main limitation, has a limited spatial resolution. So you will not see anything below 0.5, 0.4, 400, 500 microns. But the reality is different, and the reality is the one depicted on the right. And the reality is that beyond the epicardial artery, there is a fine network of small vessels that make up the microcirculation. Now, 5 years ago, with my good friend Filippo Crea from Rome, we tried to put some order in this field of microvascular disease. And we came up with a proposal of a clinical classification. Now, what interests us is the type B. And the type B is the coronary microvascular dysfunction in the presence of myocardial disease, either secondary to systemic disease or genetic, as you like to call them these days. And we also try to classify the pathogenetic mechanism of microvascular dysfunction. Now, if you focus on what is in the red box, you see that one feature of causing microvascular dysfunction, coronary microvascular dysfunction, is vascular remodeling, which is typical of two diseases, hypertrophic cardiomyopathy and arterial hypertension. For instance, this is not the case in aortic stenosis, which is another condition characterized by microvascular dysfunction. But in aortic stenosis, you don't find the same kind of microvascular remodeling you find in hypertension and hypertrophic cardiomyopathy. There, the microvascular dysfunction is due to hemodynamic causes, such as increase in intramyocardial pressure, prolonged ejection fraction, a prolonged ejection period with reduced diastolic times. Good. So let me give you some examples. So this is a normal intramural arteriole. This is the bar is 50 microns, so we're looking at about 30 micron arterioles. This is an arteriole from an hypertensive. You can clearly see the difference with respect to the control. There is thickening of the tunica media, and there is also some degree of thickening of the internal elastic lamina and subintimal hyperplasia. Now, this is what happens in hypertrophic cardiomyopathy. Similar patterns, but more severe. You see the degree of subintimal thickening, the degree of thickening of the internal elastic lamina, and above all, the thickness of the tunica media are much greater than those in hypertensive, but it's the same kind of disease. And this is taken from a wonderful paper that Barry Merong and Robert Roberts published a few years ago describing this pattern. And I was always amazed to look at this section of the septum in this patient, where you clearly see the intramural arterioles with such a thickened tunica media. Now, how do we transform this anatomical data into pathophysiological information? Well, vessels below 300 microns are responsible for more than 95% of resistance to flow in the coronary circulation. And as you know, the coronary circulation is the only circulation, together with the kidney circulation, to have a very important flow reserve, which is 3 to 5 times resting flow. Now, when you go from resting to hyperemia, what you do, you dilate the resistance vessels and you allow flow to increase without any change in perfusion pressure. So the correct functioning of these small vessels is the conditio sine qua non for obtaining hyperemia and for obtaining an adequate flow increase when you increase the workload. And this is what goes wrong, and this is the very basic mechanism of myocardial ischemia. So, summarizing, in a normal heart, you increase the work and you have a parallel increase in flow up to a maximum. This is also because the extraction of oxygen from the arterial blood in coronary circulation is almost nearly maximum. So if you want more oxygen, you've got to have more flow. If you have a coronary stenosis, what you will do is you increase work, increase flow up to a point, and then your flow reserve is limited by the stenosis, and you plateau and you develop ischemia. However, you can have the same thing in the absence of a stenosis, and we assume that this, if you measure flow and you see that when you increase flow, you cannot increase above a certain limit, this is the demonstration of microvascular dysfunction. And later on, I will prove you that my assumption is right. Okay, now let's wrap up. Now, here on the left is what my mentor, Attilio Maseri, taught me when I was a trainee in cardiology. So ischemia could be due to two main mechanisms. The one due to classic coronary disease, so you have a plaque. If you're lucky, the plaque is a fibrotic plaque. You develop stable angina. If you are less lucky, you have a vulnerable plaque. You develop an acute coronary syndrome. The other mechanism is a mechanism which is functional, which is due to vasospastic disease. Again, if you have transient ischemia, you have Prince-Medal angina. If you have a prolonged spasm, you may go into an infarct due to vasospasm, although this is quite rare. Now, my view is that in addition to these two mechanisms, there is a third mechanism which involves the coronary microcirculation, and this leads to microvascular dysfunction. So you can have an impairment of flow reserve due to microvascular dysfunction with different mechanisms. This can be preclinical in patients with risk factors, so you study patient with hyperlipidemia, patient with diabetes, and you see that the flow reserve is limited because of microvascular dysfunction before they develop any epicardial disease. And this contributes to myocardial ischemia, which is observed in cardiomyopathies. You can have another form of microvascular ischemia, which is more prolonged, and for instance, an example of this is Takotsubo cardiomyopathy. So this is my view. Maybe you don't agree, but this, is trying to put some order in an evolving field. Now, as I was mentioning in this slide, the problem is there is no in vivo technique to measure or to assess the function of the microcirculation. So how do we go about that? Well, we test the function of the coronary circulation by measuring parameters such as myocardial blood flow that depend on a correct functioning of the coronary microcirculation. Now, the best technique to do so, although it's a complex technique, is expensive, but it's a wonderful technique, is called positron emission tomography. This allows measurement of absolute myocardial blood flow. So this is a study that Ornella Rimoldi and I did. This is one of many studies where in animals, these were pigs, flow was measured with microspheres and at the same time with PET. And you see that there is a good relationship between the two techniques. There is a good agreement between the two techniques. This is another study that this was done by Philip Kaufman when he was in London with us, where we tested the reproducibility of this technique, and it's very reproducible, both at rest and during maximal vasodilatation. So this is a sound, reproducible technique to measure non-invasively myocardial blood flow. Okay, now we go back about 20 years. And this was my first paper where I applied PET to measure myocardial blood flow in patients with hypertrophic cardiomyopathy. I still remember the patient came from Pescia. There was a good friend in the hospital in Pescia who sent me this patient and said, let's look, this patient have chest pain, but they have normal arteries. Let's see what goes on in their myocardial blood flow. And what we found that in hypertrophic cardiomyopathy compared to normal controls, there was a severe blunting of flow. So flow during hyperemia did not increase as much as in control. But the big thing was these were all ASH, so these were all septal hypertrophies. We found that not only flow was limited in the septum, but also in the free wall. So it looked like, although there are contrasting data, and it looked like that the problem was not limited to the septum, so was not mimicking the geographic distribution of hypertrophy, but was a problem that was different from the geographic distribution of cardiomyocyte hypertrophy. Many years later, when we applied this to the genetic, we found not only that, of course, the original observation was confirmed, but that if you are genotype positive, you are more likely to have a more severe microvascular disturbance than if you are not genotype positive. And this, I'm sure, is the patient you've seen already this morning, but it's always good to see things twice, maybe to fix them in your brain. So same phenotype, different genotype, look at the flow response. So blue means very, very low flow. So this patient has a very low flow all around the heart as compared to the other subject that has a normal response to flow. Now, does this lead to myocardial ischemia? Yes. So this is a very old study, but one of those solid things we did many years ago when we put catheters in the great cardiac vein, pace the patient, take blood to measure lactate concentration. So these patients do become lactate producers during pacing. For those who are not familiar with this, lactate is the product of anaerobic glucose metabolism, and is only released during condition of myocardial ischemia. So many of these patients do develop lactate release. So indeed, the flow reserve impairment due to microvascular dysfunction can be severe enough to induce myocardial ischemia. Good. Now, let's leave hypertrophic cardiomyopathy. This is a case of severe secondary LVH due to hypertension. This is a courtesy of Dudley Pennell from the Brompton Hospital. On the left, you have MRI perfusion. At rest, you see that perfusion here in white is homogeneous. This is during adenosine stress, and perhaps you can see the black halo in the subendocardium, which means that there is a hypoperfusion which occurs selectively in this region of the inner half of the myocardium. So the same is true in hypertension. Now, these are unpublished data that Dr. Rimoldi did in patients with LVH secondary to hypertension. So these are 30 patients with LVH due to hypertension and 10 normotensive controls. So these are the flows. Now, to do this study, we used a high-resolution PET camera that allows discrimination between the epi and the endo. So you can measure not only absolute flow, but selective flow in the subepicardium and the subendocardium. And we found that during stress, both the epi and the endo had a severe blunting of flow reserve. And this is similar to what we observed. I think Lubna did this study years ago when she was in London. We found the same, that you have severe transmural ischemia in hypertrophic cardiomyopathy, albeit sometimes it's more severe in the subendocardium. So again, you see many analogies between these two conditions. Now, so we've seen the anatomy, we've seen the physiology, the pathophysiology. I've given you some, I hope, convincing demonstration that these patients have severe microvascular dysfunction and ischemia. Now, how these translate into the tissue? So what are the possible consequences of these hemodynamic disturbances at the tissue level? Now, I want to share with you this very, very nice paper that was published 3 years ago in JACC. Now, what the authors did, they had a series of Ockham patients undergoing myectomy, septal myectomy. So, and all the patients had MRI. And what they found that before myectomy, these patients had evidence of late gadolinium enhancement in the septum, and using the myectomy ex vivo, at histology, there were evidence in the same area of severe microvascular remodeling. So this is not a proof of a causal link, but is strongly suggesting a link between this anatomical remodeling and the presence of late gadolinium enhancement in the septum. This is a paper we did with Jacopo, Roberto Chagrin, and Franco, and in this patient we did both PET, and for instance in this case we could demonstrate hyperperfusion in the septum, and we could show that in the same region, I admit the quality of this MR is not the best, but there was clear evidence of late gadolinium enhancement in the same area where you have severe microvascular dysfunction. Then we had the chance to look if this microvascular dysfunction had a prognostic indication. So we took a series of about 50 patients, and we divided patients into third tiles according to the severity of flow impairment. What we found that the patients who were in the lowest third tile of blood flow, this one, so this one, so these are the patients who had the least increase in myocardial blood flow. They were those who were more likely to progress towards end stage. So there was a link between the finding at PET at time 0 of a severe reduction of flow during hyperemia and the development of end stage. Again, it's not a proof, but it's strongly indicative. And when we did multivariate analysis, this was an independent predictor of end stage. Now, Also, the group from Oxford, Stefan Neubauer, came to rescue. This is a very nice paper where patients were grouped according to the flow response, and here, hyperemic blood flow, and those with the lowest flow, here on the left, were those with the greatest amount of late gadolinium enhancement. And those with the highest percent of late gadolinium enhancement were also those with the greatest wall thickness. But again, some kind of link between the flow response and the presence of gadolinium enhancement. And we have seen these slides already, and it was demonstrated that, again, the percent of late gadolinium enhancement was responsible for the reduction, or at least was associated with the most severe reduction on ejection fraction. So my proposal, which is not fully proven, is that there is some kind of link. And, you know, I really enjoyed the discussion this morning. And one point that came out is, okay, but we're missing something. You know, when we stratify patients, PPV is a sort of weak, NPV is better, but PPV is weak. So what is the missing link? My proposal is, at least in part, the missing link could be microvascular dysfunction and ischemia, which in turn lead to replacement fibrosis. That is what we see at MRI with gadolinium. Now, does this correlate? Does this resemble what we see in hypertension? Yes. So this is a beautiful paper that comes from the Berlin group, where LGE was done both in patients with hypertrophic cardiomyopathy and patients with LVH due to hypertension. Look, they found, and this goes well with what we have seen, that 70% of OCAM patients had LGE, but look, 50% of patients with hypertension had LGE as well. Again, I can't tell you how many had CAD, but a good proportion, I'm sure, did not have CAD. So in this case as well, my assumption is that somehow LGE is a correlate of microvascular dysfunction. Now, the last piece of information, I think it's the most important, goes back almost 10 years ago, is in the same cohort where we demonstrate progression of the phenotypes towards end stage, we could also prove that those patients in the lowest tertile of flow, so these are the patients that at time zero had a PET scan, and their response to dipyridamole was very, very bad. So the flow ranged from 0.6 to 1.1. Now, normally, this flow should be between 3.5 and 5, so no change in flow. These were the patients with the worst outcome. So I think clinically, and this is what matters to us as clinicians, the degree of microvascular dysfunction is a predictor of outcome. So if we try to revisit the scheme that Dr. Drazzer proposed in the beginning, my idea is that somewhere here, in addition to MI, in those with no MI, microvascular ischemia could be responsible for the progression to heart failure and hypertension. Equally, in hypertrophic cardiomyopathy, microvascular remodeling, perivascular fibrosis, a severe limitation of flow reserve will provoke ischemia, lead to replacement fibrosis, which in turn could be responsible for the progression to the end-stage phenotype. Okay, in the last few minutes, I hope if I have 2 more minutes, my talk, I would like to share with you some new data. Can we treat microvascular remodeling? Because this is what matters in the end. This is a study we published last year in hypertensive because we could use these drugs because they are established drugs in hypertensive. Hopefully, we're going to do the same in OCA. So we use this ACE inhibitor and diuretic combination, which obviously reduce blood pressure, also reduce significantly MRI, and most importantly, after 6 months of treatment, we saw a significant increase in myocardial blood flow. Now, do you remember I made an assumption that blood flow, maximum blood flow, represents microvascular dysfunction? Now, to prove that, we did an ancillary study in a model of hypertension, which is the spontaneously hypertensive rat. So, like in patients with hypertrophic cardiomyopathy, SHR have a severe remodeling of the coronary intramural arterioles compared to the WKY controls. And if you calculate, this was done by Giulia Damati and Max Mancini in Rome, if you calculate the area between the intima and the tunica media, and the adventitia, you see that the SHR has almost a threefold increase in the area compared to the controls. Now, we repeat the study with the same drug regimen and see we found exactly the same results. But contrary to the patient, we could sacrifice the rats, do histology, and this is what we found. We found that those treated with the drug compared to those treated with placebo had evidence of reverse remodeling of the intramural coronary arteries. And this is what happened to the tunica media area, was greatly, and this corresponded with an increase in flow. So my assumption that if I look at maximum flow as an index of microvascular function indeed was correct. Now, generally, the wellness, the equilibrium of a tissue depends on a series of different stimuli. On the one hand, stimuli that promote growth, and in the case of hypertension, the most important is angiotensin II. On the other hand, stimuli that inhibit growth and inhibit platelet aggregation, such as nitric oxide and bradykinin. Now, one explanation of why ACE inhibitors could lead to reverse remodeling is that they promote the concentration of NO as well as the concentration of bradykinin. So it is important not to confuse all drugs. So, for instance, I'm not sure whether other drugs that block the renin-angiotensin system will lead to the same result, but we shall see. And I think I will stop here, but taking this wording from a recent review we wrote with Jacopo and Roberto. So coronary microvascular dysfunction can lead to myocardial ischemia and replacement fibrosis in Occam, resulting in adverse LV remodeling and dysfunction. Pilot proof of principle studies are in the process to be started to ascertain if established drug, proven effective in other conditions, may lead to reverse of this phenomenon in hypertrophic cardiomyopathy. Thank you very much indeed.
Excellent job, Paul, as usual. My question is maybe off topic. Elena Biagini this morning and you now have shown that the thicker the wall, the more fibrosis there is. So my first question is the percentage fibrosis the same, independent of thickness? And my second question is, does this matter? In other words, what do you think matters most? The raw amount of fibrosis or the percentage fibrosis?
Well, I don't have data to answer your question. Obviously, I agree that the absolute thickness of the septum is important, is a predictor. We've seen data this morning by Lubna where she was showing that the thickest portion of the LV were those with more LGE. An explanation of this could be that for an equal amount of microvascular remodeling, the thicker the wall, the more important the extravascular component of resistance becomes. So this is the pressure that gravitates upon the vessels from the outside, and perhaps also the amount of perivascular fibrosis, because the other thing is, with the progression of increasing the thickness, there is also a progression of perivascular fibrosis. So this is important in limiting the already limited excursion of these vessels. So, but I think this is a very important point. We need prospective studies where we could correlate microvascular function with the anatomical data and the outcome data.
Thank you very much. Allow me one question from this position of chairman. You mentioned that the remodeling is probably, and the capacity to dilate of those small vessels is one mechanism, but there are accumulating there is accumulating evidence that probably a part of the microvascular dysfunction may be related to abnormal shunting of the blood at the level of capillaries. So what is your point of view, how much this phenomenon may play a role?
Well, I mean, this is an important point. I mean, obviously, there is also capillary rarefaction, which is somehow is related. But from a physiology point of view, resistance lies in the arterioles. So the problem originates from the arterioles because this is the district where resistance is made. So if you have a problem there, what happens downstream is almost irrelevant. But however, the capillary rarefaction contributes to make the situation worse, and it's an aggravant leading to myocardial ischemia.
Thank you very much.
Paolo, thanks for a very elegant and eloquent presentation. My question is that when you talk about drug therapy, perhaps to modulate microvascular dysfunction, would you envisage enrolling patients in such a trial before the apparent LGE or MRI? Because my feeling is that in the few patients that we have serial MRIs, the LGE doesn't change much over time, unless, of course, they're progressing to end-stage disease with HOCM. So do we need to catch these patients at an earlier stage and do the PET study before, perhaps, the LGEs manifest?
Thank you, Rubna. It's very clever. I think this needs to be a stepwise strategy. The first thing I want to do is to do 1 or 2 small studies using different drugs with different points of attack to see, of course, how well they're tolerated, but above all, to see whether or not these drugs, and for how long, have an impact on flow. If they don't, then, the rest is not warranted. So the first study will be done in HOCM patients, consecutive patients, compared to control. I expect most of these patients will have a limited flow response, and then repeat the study after a given time of drug treatment and see whether I can, like I did in hypertensive, improve the flow response. Then, once I've done this, of course, what we need, and this was coming from the discussion of this morning, we need prospective studies. So I think, for instance, we need to plug in the microvascular issue into a larger study, have a subgroup of patients that would be followed, where we can follow the evolution of the disease, follow the evolution of LGE, and correlate it with microvascular.
Okay. Last question.
Congratulations, Paolo. So microvascular dysfunction in HOCM and in hypertension is mostly a disease of the media. What is the role of, if any, of endothelial dysfunction in these models?
Well, the coronary circulation is like an orchestra. So the microcirculation must play together with the macrocirculation. Now, one of the functions of the endothelium is when you change flow downstream, you will modify shear stress upstream, you will release substances, mainly nitric oxide, to readapt the shear stress to the increased flow, because when you increase flow, there is a transient period where shear stress is decreased. So remember, the good shear stress is high shear stress. So of course, in the setting of a condition where you have a limitation or somehow a dysfunction of microcirculation, this will be reflected in the function of the larger vessel, because the endothelium plays an important role all over. Nitric oxide predominantly on larger vessels, EDRF more in the microcirculation. But this is an orchestra. So if one component doesn't work, the rest is, if you hurt your foot, then your knee, then your ankle, and then the spine. So.
Okay, let's move to the next presenter.
I think Professor Yacoub, he must be allowed. I'm sorry. I shouldn't do this, but... Maestro.
Paolo, thank you for such a great talk. Just to support that last point about the function of the endothelium, and that comes from bridges And in patients, we have evidence that in patients with bridges, that there is endothelial dysfunction just distal to the bridge, which persists for only a few days. And then when we looked at endothelial function after that, there was marked recovery of the endothelium. So that supports what
Thank
you're
you.
saying.
I think I must leave now. Thank you.